Next speaker is Francisco Garcia, challenges and new approaches to cervical cancer prevention along the U.S.-Mexican border.
Thank you. Thank you, José and Rolando, and thank you to Tom Cox for inviting me to talk a little bit about some of the unique challenges that we face along the U.S.-Mexico border. It is a little, hard to follow José and Nubia because some of the challenges that are faced in our area are actually quite different. But I think are really informative. In each of our countries, whether in the developing or the developed world, we have small but very important pockets of incident disease that is leading to unnecessary cervical cancer mortality. And that's actually what my focus is on, and that's where we have tried to make an impact. So just in terms of faculty disclosure, I have no personal financial obligations to disclose. You should know that the University of Arizona has contracts with pharmaceutical and molecular testing companies for the conduct of clinical trials, but that I derive no direct benefit from these because I'm an employee of the state of Arizona. So for those of you who are unfamiliar, the U.S. and Mexico share a 2,000-mile border that has historically been the source of a lot of controversy as well as the source for a lot of public health challenges, not just in cancer prevention, but other chronic disease, and is really becoming more and more contentious as political, sort of the political acrimony around it has grown. This 2,000-mile what we consider the border is the 100 kilometers north and south of the U.S.-Mexico international boundary. This will include 4 U.S. states and 6 Mexican states, 44 U.S. counties, and 80 Mexican municipalities. In total, the region is a fairly large region, including 14.2 million people, and every day along the border, and this is in the background, you can see the border crossing in Mexicali. There are at least 1 million legal border crossings, and add to that another 300,000, and we're down this year, extra legal crossings that occur. In the U.S., border communities are really important and actually quite distinct. In the U.S., this is about 7 million individuals. Mostly, these communities are, by and large, 50% Hispanic ethnicity, characterized by low levels of educational attainment compared to the rest of the U.S. It includes 3 of the 10 poorest states, 3 of the 10 states with the lowest insurance coverage, and 2 of the 10 poorest counties, 3 of the 10 poorest metropolitan areas. One of the things that's really important to understand when you're thinking about border communities, whether it's here in the U.S. or whether it's anywhere else, is that these communities are actually quite heterogeneous. And along the U.S.-Mexico border, we have 25 different tribal communities which exist on both sides of the international boundary. These are situations where they didn't cross the border, but the border crossed them. In 2010, the U.S.-Mexico Border Health Commission established a set of objectives that has really guided the development in that area. And number 2 among those objectives was the whole issue of reducing breast and cervical cancer mortality. This is a map from our colleagues at the Centers for Disease Control that really summarizes some of the SEER data from 1990 to 2006 and shows you exactly where our Hispanic origin women dying of cervical cancer. And what you can see is that those deaths of cervical cancer are by and large limited to the U.S.-Mexico border, although some in Florida also. There has been some exquisite work done by our colleagues at the Centers for Disease Control, really trying to understand the dynamics of cervical cancer screening and the manifestation of HPV-related disease in border communities. This is from Stephanie Coughlin at the Centers for Disease Control, and what she's showing here is invasive age-specific cervical cancer incidence per 100,000 women. What I want you to pay attention to on the x-axis are the age at diagnosis for these cancers. But what I want you to pay attention to is that the fact that at every age group after 25 years of age, there is a significantly higher incidence of cervical cancer in border counties regardless of ethnicity, compared to the rest of the country. And this is a phenomenon that persists between, at 30 to 75 years of age. So this is a really important thing as we start to do some public health planning in these areas. In Arizona specifically, we see this manifested as very, very striking differences in mortality. This is the age-adjusted mortality by race and ethnicity. And what you can see is that if you are a Hispanic woman in the state of Arizona, you're twice as likely to die of cervical cancer. If you're an American Indian woman in the state of Arizona, you're almost four times as likely to die of cervical cancer as the white non-Hispanic counterpart. In the U.S., utilization is driven by a lot of things, not the least of which is insurance. And we understand that that has a tremendous impact on the ability to access cervical cytology in this case. We know, for instance, that for white non-Hispanic women who are uninsured, only 63% of them will report having had a PAP within the last 3 years, compared to 54% of Hispanic women. We also know that there is a certain amount of heterogeneity even within Hispanic populations, as there are within any other racial or ethnic minority, so that we see big disparities in terms of the utilization of these screening services across different subgroups. So you can see here, for instance, that Mexican origin women, for instance, have the lowest rate of screening utilization, 72%, among the Hispanic subgroups, compared to, for example, Cuban women who have a higher utilization rate at approximately 86%. We actually, like I said, know a lot about screening in border populations, and there was an article that came out that has not gotten really the attention that it deserves. What this was a compilation of behavioral risk factor surveillance data, as well as the ENSA, the National Health Survey that is done in Mexico. And it was for the year 2006. This was an analysis of all the border counties, as well as all the municipios, the equivalent on the Mexican side. It included 1,724 U.S. women and 1,454 Mexican women, all ages from 20 to 70. Because of the way that the questions were asked, which wasn't exactly the same, the authors chose to look at screening utilization during the previous year. And so what you can see is that there's obviously in these border communities, when you look at women in the U.S. versus women in Mexico, twice as many women on the U.S. side of the Mexican border will report being screened, 65 compared to 32% on the Mexican side of the border. What's interesting when you start to delve into these types of data is that screening utilization really is impacted by a lot of different things, which we've always known for this population, marital status and insurance. But what's also interesting is that there's a fair amount of heterogeneity that plays itself on either side of the border. For instance, in the U.S. in particular, women less than the age of 25 are more likely, significantly more likely, to have been screened than women over the age of 30 and the older age groups. That's not the same phenomena that you see in Mexico. By contrast, for instance, educational attainment for this particular group of women in Mexico, lower educational attainment actually ended up being associated with higher levels of coverage. An observation that was interesting, but that may reflect the way that services are delivered through the public and private sector. When you look at cancer screening in border communities, and we use the behavioral risk factor surveillance data a lot, you also see that there's a certain amount of a gradient as we get away from the U.S.-Mexico border. Here's PAP, that women reporting a PAP more than 3 years ago. And so you see that for Hispanic women, they will report it 15.9. Across the U.S., they will report it about 15.9, 16% of the time, very similar to what non-Hispanic women would report. However, when you look specifically at border counties, you see more than twice the rate of reporting of non-compliance with cervical cytology screening for Latino women, for Hispanic women, compared to women who are non-Hispanic, who live in those very exact same communities. we performed this is borne out by our assessment. We've been very interested in how specifically rural communities, the heterogeneity within rural communities in terms of screening practices. This was a study that we did, a population-based sample of post-reproductive age women in Yuma County, a very large rural border county, looking at the effect of Hispanic origin. So in total, 73% of women reporting having had a PAP in the last 3 years. However, look at the differences between Mexican-born Hispanic women and U.S.-born Hispanic women, with U.S.-born Hispanic women having significantly lower rates of reporting screening utilization during the previous 3 years, and white non-Hispanic women in this case having very similar rates to the Mexican-born women. Cervical cancer, this whole issue of how the factors that sort of impact cervical cancer screening utilization really sort of begs the question of, what is it that we can do differently for these different population subgroups to help us figure out what are the best approaches. I'll just draw your attention to a couple of things that I think are really relevant. Obviously, having access to insurance, having access to a provider in the previous 12 months, and really having providers who are assertive about their recommendations for these kinds of services ends up being kind of a critical factor for all three groups. This is a slightly different take. We also looked at the Arizona and New Mexico behavioral risk factor surveillance data for 2006 to 2008 for all women over the age of 40 with cervixes. And we wanted to ascertain how many women would be out of compliance with some of the newer screening recommendations. Clearly, women who are having a pap smear at greater than 5-year intervals are clearly out of compliance with that. We also wanted to understand not just the effect of race and ethnicity, but the effect of rural and urban status, because in the state of Arizona and in the state of New Mexico, we have very large rural areas. And what you can see for the population as a whole, and this included about 11,000, almost 11,000 women, what you can see is for the population as a whole, women who lived in rural settings were twice as likely to be non-compliant or out of compliance with their cervical cytology recommendation. As a group. You didn't see that large magnitude of difference for Hispanic women, whether they were in urban or rural communities. You didn't see that for American Indian women, but look who we saw it for. We saw very, very significant differences for rural living white women who had very high rates of underutilization and really drove that for the entire population. My friend Cosette Wheeler at the University of New Mexico runs what is our only PAP HPV population-based registry in our country, in the U.S. And one of the things that she and I sort of have a lot of agreement around is that the issue is that prevention doesn't end with screening. Prevention needs to be linked to diagnosis and treatment. And in our communities, in border communities, we have particular problems with the linkage between diagnosis and screening. I'll just draw your attention to a couple of things. The different color lines indicate the severity of the PAP, right? So just pay attention to that green line, which is an H-cell PAP. Notice that for most women who are going to get a diagnosis from their H-cell PAP are going to get it at about a year. But after that, only another 10% of women will actually receive a diagnosis. What that means from a practical basis is that 30% of women with an H-cell PAP are going without an actual diagnosis or not coming into colposcopy and not having a biopsy. I think that has fundamental and profound implications. I was originally really shocked by that until I reviewed a paper from that reflected the experience in the California public sector, where it was more like 50% of women with abnormal cytologies were not actually getting a diagnostic follow-up. These are really, really profoundly important kinds of observations. She does something similar here. In this case, these are women who have a diagnosis of CIN2. And what she's trying to describe here is how many of those women actually go on to have a LEAP. And what you can see is that 50% of those women are going to have a LEAP or are going to have diagnostic surgical resolution within about 3 months. But there's a significant proportion, somewhere in the neighborhood of 40%, that are actually never getting a surgical solution to their problem. I think that is extremely important. One of the things that I think is really important to understand, and I think that all of you understand, is that HPV doesn't discriminate. We know what causes cervical cancer. We know that it's type-specific, persistent infection. We know that that's the case whether you are in what I would call a resilient population, an upwardly mobile, good healthcare access, in our country, white population, or if you are in a vulnerable population. What's different between the two populations isn't that biological phenomena. What's different between the two populations are what I call contextual factors. They are all those other things that interfere with the delivery of services and diagnosis and treatment that get in the way of a woman getting diagnosis and treatment. So those are things like the availability of services. On the Indian reservation, when a 60-year-old grandmother who's a shepherd out in the Second Mesa has to drive in 3 hours into the closest health center, expose her genitals to a male provider in order to get cervical cancer screening, it's not going to happen. It's not going to happen. Immigration status for us is a huge and important issue. Even under the Centers for Disease Control Breast Cancer Cervix Early Detection Program, which has done wonderful things in our country to increase the coverage, to bring screening to the women who most need it. For some of our states, New Mexico, Texas, and Arizona, we are not able to afford therapeutic services, not attached to the therapeutic services that are required for those women whom we identify with pre-cancer of the cervix. There's important systemic and obstacles and obviously cultural and linguistic things that have something to do with it. But ultimately, those are the kinds of contextual factors that really make the disease be manifested so differently in these two different populations. What I worry about when I think about comprehensive cervical cancer prevention in our most vulnerable communities is that we actually have a system that works pretty good in some senses. In the U.S., whether it's in a border population or not, we've gotten the screening thing down, I think, pretty much. The problem is that linkage with diagnosis that I think is still a problem, the linkage between diagnosis and treatment. And now really thinking about how we incorporate vaccination into this paradigm so that we can do it using a holistic approach. I think reducing cervical cancer in U.S.-Mexico border populations really requires just 5 basic elements. It requires informed women and communities. I can't overestimate the importance of that. It requires providers who are up to date, and in our country and in the countries of our collaborators in Mexico, there are still significant educational challenges to be broached. It requires access to health care, and this is a fundamental thing. But one of the things that I'll point out to you is that even in populations that have theoretical access, American Indians, for instance, the effect of that access is not played out. That is, the rates of underscreening are terribly high. Finally, it requires evidence-based policy and engaged researchers. And with that, I think I will finish. Thank you very much for your attention.